AP. Okay, go a little bit. Let's see where is lateral here. This is the arm here. So okay, get me a little bit. No, actually, we're gonna oblique the other way.
Other way.
Yeah. That's it. That's it. See? That's
Okay,
decent.
That's the joint.
So I will go cranial. More. That's it. Nice. You see, guys? So just to clarify,
It's never this clear in real life, ever.
scapula, medial scapular border, joints. Here the process, and this is the supraspinatus. The spine of the scapula. You see the spine of the scapula, clavicle, to the spine of the scapula, and this is the kind of the anterior aspect of the scapula itself. A lot of times in real patient you don't see it that well because this is your backbone that you don't want to go anterior to it. Otherwise you're gonna go to the lung, and this is the notch. This is the coracoid. So just the medial to the coracoid. Where's the notch? And again, variation. Sometimes it's the V shape, the U shape. Sometimes there's no notch. It depends in the patient. So to see it well, we go cranial and some ipsilateral to clear it up. So you want to go for medially, touch the spine, and then move all the way. So I will go from the other side. Ideally, you feel the thoracic spinous process, just medial to the thoracic spinous process, usually T3, T4, which you're gonna enter. And this is where we're gonna go your first incision. Yes. So let's say I'm coming from here, X-ray. I'm not in the ideal position, but this is, I think, will take me down. So into the skin, X-ray. I want to be superficial, safer, so I directed my needle tip up. And I want to touch the bone. X-ray. X-ray. I'm not sure this is the bone or just the plastic. I think it's the bone. X-ray. So I'm above the spine of the scapula.
The entry
It's
point
plastic.
is over what? Your entry point is.
So my entry point is just like in the lateral to the thoracic spinous process.
Okay.
Ideally here like a T3-ish, or 3-ish, T3, 4-ish, just lateral to the spinous process because you need some like distance. It depends on like the patient. Sometimes you find yourself going more medially, but ideally here I think I touch the spine of the scapula. I think I touch the spine of the scapula here. X-ray. You can check lateral, but with lateral here it's very, very difficult to see really with the lungs, with the ribs. You will not see good. We can try lateral. We want to try lateral to see if we can see.
Or like a
Ultrasound. I just told.
contralateral oblique.
Yeah.
You can try that, but I mean the main thing with the lateral or contralateral is that you want to be sure that you're not like deep to the scapula, and you are under the like it's above the rib or in the lung. Well, I use ultrasound.
Yeah.
Because it's very like cumbersome in the OR to go lateral and with the drapes and maybe you're not the tech is not comfortable. Sometimes you need like 10 minutes to get the lateral view. If you have the ultrasound, just put it there. You are above. Save you imaging, save you exposure.
Kind of like this view,
On the wide.
Yeah, show me, Adam.
the wide view. You're kind of getting there right now.
getting
I got you.
Yeah.
Yeah. That shows that you're not too far anterior, posterior. You're kind of right in the wide.
Because you can sometimes lose it and you find yourself like in the lung.
I mean that's on a.
I think we are okay.
Very clear.
Yeah.
But yeah,
You want it in the wall. Okay, that makes sense.
correct.
Yeah.
Yeah.
Okay.
Just above.
Take it.
And back to the same view. That's a good one there. So you will keep advancing. If you are touching the bone, it is safe. So I touch the bone here. So watch and touch the bone. I can just switch up and advance half a centimeter or so. Okay, X-ray. X-ray. I mean, this sound is not I'm not familiar with the sound in my patients.
Nails on it.
Followed by some. Ow!
I'm like through the bone or something. So I'm almost there. So I think this is a good location. I can try the lead blank. I don't think so the lead blank will advance in this plastic model. I can
Yeah.
try. I like to use ultrasound because you can, you can puncture the suprascapular nerve and artery. And you don't see it just with fluoroscopy. So it doesn't advance as we expected. X-ray. So this is acceptable. I needed just maybe a couple of millimeter more because you want maybe a couple of contacts distal and a couple of contacts proximal.
Well, I think they need the ultrasound. Need the ultrasound? Yeah, you need it? Yeah, sure. Yeah, not right now. We can just put it right outside that door.
So it does not advance.
Do they need it right now?
Yeah.
You need to have your bevel pointing towards that, towards the notch, because it's the nervous goes towards it.
Yeah. It's better just across
And just go across.
to capture it.
Okay.
And then here I need to advance a little bit more, but with the cadaver here or with this plastic model, I cannot advance it more. But maybe you can create a little bit of a bath.
I see.
X-ray, you have the control or
This one? Yep.
okay. So ideally I need a little bit farther because the nerve, as you know, crossing here. So if the lead moved back, we're gonna lose it. So maybe I will try to advance a little bit more still. I'm not sure how good this of a plastic model really.
They didn't need it? They said they
soon.
would like it back in about half an hour.
Half an hour, so we want to start something with ultrasound, X-ray. Maybe do the tibial X-ray. So I need a little bit farther. X-ray. So this is acceptable here. So you want it just to be across the notch to capture the nerve. Okay, X-ray. So this will be acceptable.
Okay.
You want to try to get it out?
I'm
You want to
holding
put
this.
your hands? Okay.
Oh, it's okay. You can do it.
So I will
Go ahead.
do with life, but I have to go to the other side, so I don't want my
Oh,
hand to
yeah,
be
yeah.
exposed. This is very.
Tough.
The plastic, yeah, is holding the needle. So,
Yeah.
but you have to understand
Yeah.
the idea and where you will put it there.
X-ray?
It's very acceptable.
You want just a little
You want a little bit fast because the nerve is lying exactly there and going laterally. So the nerve course is that way. So you want to capture. So you needed just maybe one contact further.
It's hard to advance.
It's hard here with the
Yeah.
plastic. It's just like a plastic.
X-ray again? No, I advanced a little bit.
And if you hit the bone and you have a resistance and you still want to capture it, you can have the arm just move it a little bit. It
One more?
will open the space.
Oh, okay.
So you needed that second lead to be a little bit more.
Exactly. Just
Okay.
one contact. There's other approach, but a more challenging X-ray. X-ray. Exactly there. So you see the sphenoglenoid notch?
Yeah.
Plastic. X-ray. It's like there. I'm going from the sphenoglenoid notch to the suprascapular. So the nerve the lead will be across.
Okay.
If you're pairing it with axillary, then maybe that
And
would
do
be-
the axillary from the same. So your entry from here, okay, and then so this is from your incisions here. You're gonna enter from down up to suprascapular, and then from the same entry. You see, I didn't change the entry point. I go from the same entry point. Your plastic is not cooperative. Your plastic is not moving.
Your entry point is what at this point, Hisham?
Just like the upper end of the axilla in the back. X-ray. X-ray. It's very tough.
Are you trying to do the axillary?
X-ray.
Is he aiming for
And
axillary?
then
Yes.
you're gonna go from the same entry to the axilla now. Very from my finger.
What's our landmark for the axillary?
It's
Usually-
ultrasound.
Yeah.
Oh, okay, I was like,
usually ahead of the humerus
Take a picture.
and the shaft, and it's usually that intersection.
oh, the,
It's
okay.
usually like right in.
Ultrasound.
It's usually like right in.
It's much easier. It's just ultrasound, but I mean, there's no really good. It's just the upper third, the junction between the head, upper third, with the neck, and the humerus. But it's just ultrasound. Just ultrasound with the quadrangular space.
Do you have it parallel? You have your lead parallel to this, or that's just across?
Ideally, Dr. Kanazi, if you are parallel to the nerve, so it would be better because the nerve is
This one.
The whole thing out?
Yeah, we're gonna try and switch to some
90 degrees. If you're
ultrasound
parallel
stuff.
to the nerve, you're gonna
Yeah.
have a better. But it's more